Patient XYZ was admitted with chief complaints of chest pain on exertion. He was a known case of CAD, post PTCA to LAD and LCX around 2 years back. ECG showed non-specific STT changes and 2D echo showed RWMA in LAD territory with LVEF of 40%. Following are the CAG images of the patient 2 years back from another center. The LAD is showing 100% occlusion. There is 95% stenosis in LCX. RI is normal and RCA is showing non-critical plaque. So the operator there decided to go for stenting to LCX as well as LAD. My purpose of showing these images to you is for you to appreciate the position of LAD stent, which is osteoproximal. Slides. No, previous one only. Previous one, this one only. Next. With mouse only. Yeah. So, yeah, my purpose of showing these images to you is to appreciate the position of LAD stent, which is osteoproximal, and to appreciate the position of jailed S1. Sorry. You can see here the position of osteoproximal LAD stent and S1, which is jailed as well as impinged. This is the osteoproximal LAD stent. And this is S1 coming here, which is impinged. So after putting stent in LAD, there was haziness at distal end of stent. The operator there decided to put another stent overlapping the proximal stent. Check CAG was done at a center which showed 100% occlusion in LAD, filling retrogradely by right system. In osteoproximal LAD, large aneurysm was present, extending till large S1. Patent stent was present in LCX, and RCA showed non-critical plaque. Patient was advised CABG. You can see large aneurysm at the osteoproximal LAD, just proximal to the proximal most stent, and S1, which is jailed and impinged previously, distal to S1, LAD is 100% occluded. Patent stent was present in LCX, and RI is also normal. So this is the stent. This is the osteoproximal aneurysm which has developed proximal to the stent, and distal to this stent, LAD is 100% occluded. This is the ariocaudal view showing the septal, which has outgrown considerably, maybe because of occlusion of LAD. And there is small aneurysm present at the origin of septal also. We can appreciate second stent here. Second LAD stent is present here. So LAD is 100% occluded distal to septal. So patient was advised CABG at our center. We can see RCA filling the LAD retrogradely, and we can appreciate two stent in LAD here. And also we can appreciate the gap which has developed in between the two stents. Our plan was to shift the patient to hybrid cath lab, where after Lima to LAD and another graft to high OM1 or RI, we can insert a covered stent from left main to LAD followed by drug-eluting stent. But because of cost constraints, attendant didn't agree, so they took discharge. After 8 months, patient again presented to us with same complaints. He had a CABG done in another center 2 months back, where they did only Lima to LAD grafting, as there was risk of occlusion of graft to OM1 due to competitive flow. Aneurysm in LAD was left as such because it was difficult to resect. As aneurysm was prone to rupture, so we opted for a bailout plan. These are the check CAG images showing patent Lima to LAD graft filling the LAD distally. And the large aneurysm which was present has increased in size. Also, there is an increase in size of aneurysm at the origin of septal. So, our bailout plan was LAD, we planned to put a covered stent covering the aneurysm. LAD was difficult to negotiate due to large aneurysm with workhorse wire coiling in it again and again. But we finally were able to park Fielder FC wire in septal branch. Another wire was parked in high OM1. Then Graft Master 3.5 into 19 mm was implanted at 12 atmosphere in distal lesion covering the distal aneurysm. Post dilatation of stent was done using 3.5 into 10 mm NC balloon at 12 atmosphere. So, the Fielder wires was used for LAD to septal, and workhorse wire, which was BMW wire, was used in RI. Graft Master 3.19 mm was used for the distal aneurysm, and it was deployed at 12 atmosphere. After the deployment of stent, there was exclusion of the aneurysm. Post and dilatation of the graft master was done, and after that result was almost satisfactory with exclusion of the distal aneurysm. Now, what about proximal aneurysm? As the proximal aneurysm was starting from ostial LAD, so placement of covered stent there was technically challenging, as slight impingement of it on ostial L6 would have led to closure of LCX. So we decided to use conventional Zabo technique for ostial stenting. We had expertise in using it in many cases of ostial LAD stenting with DES, but with covered stent it was our first case. Steps of it were: the 3.5 into 19 mm graft master stent was prepared with low pressure inflation with protective sleeve in place while exposing proximal struts so that proximal struts got lifted. The remainder of the stent was compressed with sleeve. The distal end of second coronary wire in high OM1 or RI was passed through lifted proximal most strut followed by crimping of the lifted strut slightly. The stent then traveled over the primary guide wire as well as anchor wire. The stent was then placed at ostial LAD. So this is the anchor wire passing through the proximal most lifted struts to RI, and this is the primary wire into the LAD, and stent was passing over primary wire as well as anchor wire. We have to take precautions in keeping these two wires separate. So here is the stent over the primary wire as well as anchor wire. The position at ostial LAD can be confirmed when we cannot push it further into LAD. The anchor wire restrained the further pushing of stent into the LAD. The stent was then deployed at nominal pressure followed by removal of anchor wire. The check shot showed good results with no coronal shift at ostia of LCX. So this is the check shot with inflated stent in place with no coronal shift and LCX as well as RI. Then post and dilatation of stent was done using 3.5 into 10 mm NC balloon at 12 to 16 atmosphere. This is the post and dilatation being done. So results were quite satisfactory with TIMI-3 flow in LAD, LCX, in LAD to septal, because the distal LAD is still being filled by Lima to LAD graft, in septal as in RI as well as LCX. The patient is in regular follow-up since then and is symptom-free.